My patient is a 72-year-old male veteran officer from Indian Army. He is a hypertensive, non-diabetic, non-smoker. He is a known case of coronary artery disease, double vessel disease. He underwent stenting for LAD CTO in 2003 with 2 drug-eluting stents. First Texas 2.7528 and 2.7518 were put from mid to proximal LAD. This was done in 2003. And this time he has presented to us with chronic stable angina for last 1 year. He gives classical history of angina while playing golf. He is quite active otherwise. His lifestyle is quite active. And now for last 3 months he has got crescendo angina. His ECG is showing LVH with strain pattern and echo is showing EF of 55% and there is a concentric LVH, no RWMA. Stress MPA was positive. So I took him for angiogram. This was done in 2020. So this we can see that there is a diffuse ISR from the proximal to the mid stent. Maximum ISR is here. Plus we can see 2 lumens running parallel to each other in the distal part of the LAD. This was probably not attended during the index procedure. So, and we can see another view also. These same findings are confirmed that these 2 lumens are running parallel in the distal part and there is a diffuse ISR. So just to summarize the finding, there is a diffuse ISR with maximum ISR near the diagonal, that is 99%, and there is dissected artery in the with dual element in the distal part, which was not attended to during the index procedure. So I first was very curious about this distal part, so I took a OCT run, and fortunately it went without any pre-dilatation. So with this, and after that only I started dilating. So this was the first run from the OCT, which shows that clearly there are 2 lumens running parallel to each other and almost equal MLAs. And that's why it was flowing till now from 2003. And there is a thrombus also in the distal part of this second lumen, that is false lumen, and our catheter is clearly in the true lumen. So, and this part is coming inside the stented segment also. So it was there before also, so which had not been addressed. So after that, inside the stent there is a calcified neoathrosclerosis with lot of calcification is there, deep as well as superficial calcification is there. And sometimes around 180-degree calcification circle is there. So this is also calcification, and this is around 270-degree, more than 270-degree calcification is there. And as we come more proximally, we can see there are uncovered struts also lying here. So that could be the cause of ACS crescendo angina, with some thrombus is seen over there. So, and as we come to the ostium part, there's a lot of calcification there also. So I don't have IVL balloon, so I started with the cutting balloon itself. So this was the findings, just to summarize, the 2 lumens, and these are the calcified neoathrosclerosis, which we had already shown. So I started with the cutting balloon. I don't have IVL here. So with 2.5 into 10, we can give a cut in the distal part, in the proximal part of the stent ISR. After that, bigger cutting balloon was used, 3 to 15. Wolverine was used. After this, again took a OCT run. I will not be showing this run completely because of lack of time. So just to summarize the findings of this run, we have achieved balloon-induced dissections here. Cuts are there in the calcium part also, and in the ostium part we have not touched it. So after this, I deployed the first stent from the distal LAD, that is covering the complete dissected part with 2.5 into 38 Dines prime, and this proximally it was brought and again dilated at higher pressure. So after this, proximal part was again dilated with 3 into 15 OPN balloon, and since this part I was seen that this was probably underexpanded stent with the calcium, it has not opened with the cutting balloon, so I used a OPN NC balloon at higher pressure. So after this, I deployed the proximal stent also. That was 3 into 38 Dines prime. After the post dilatation was done with 3.5 into 12 NC, and with this was the result. And after this, I took another OCT run just to see the expansion part. So I have achieved a good expansion, that is around 98%, distal part 92%, proximal part 98%, and all stent is opposed well with post dilatation, and there is no edge dissections, in the proximal or mid part. And just to summarize these findings, so I've got a good expansion and MLAs, a minimum stent area, distal part is 4.96, in mid part is 6.99, 5.62, 8.52, and good expansion is there, and LED ostium I have not touched. So after this, I wanted to do follow-up angiogram also, and wanted to fix the dominant circumflex, which I had not done during this procedure. So after this, the stent was flowing very well, and after 8 weeks, and did the OCT pullback also. Again, stent expansion is good after 8 weeks. So after this, I fixed the LCX to OM with another stent, and then did the OCT run from there also. Expansion achieved was around 95%. So this patient has now completed a follow-up for 1 year and is uneventful. Echo is done at 12 months, is 55% EF is maintained, and there is no ardeliome. TMT is negative at 10.2 mets. So take-home message from my case is that there is calcified neoathrosclerosis, malopposition, and uncovered struts, which were all diagnosed in this patient presenting with very late stent failure due to first generation drug-eluting stent. And in addition, my OCT also picked up old unattended dissection, which was left during the index procedure, and it was flowing with the parallel lumen appearance. So this patient was now optimally managed with cutting and OPN balloons, and this was followed by second generation evolution eluting stent deployment using the OCT guidance optimally. And thus OCT does help this in optimal management of this very late stent failure in first generation drug eluting stent, as well as this picked up this unusual complication, and which was addressed during this procedure.